If you have a cancer diagnosis or know someone with a cancer diagnosis, you may be advised to see a radiation oncologist. So tonight on Focusing on You, we're going to talk about what a radiation oncologist is and what sort of treatments are offered. So that will be on Focusing on You tonight. Good evening. My name is Lisa Cawthorn. I'm here as a volunteer for Hope Abounds. I serve as a patient advocate. I'm also an oncology nurse or cancer nurse and a cancer survivor. And we're going to talk to you about radiation oncology here on Focusing on You, which you can find on our website or on our Hope Abounds app, also on Roku and Apple TV. So with us tonight, we have one of our local radiation oncologists, Dr. Patrick Maguire. So welcome.
Thank you.
Well known in the community. So I want to give everyone a little bit of the background here. You're with Coastal Carolina Radiation Oncology here in Wilmington, North Carolina. You're certified through the American Board of Radiology, correct?
Right.
You went to undergrad at Haverford College in Pennsylvania and then got your medical degree at Penn State. And then I laughed beforehand and I said, but you got to North Carolina as soon as you could.
That's right.
So then you went for your residency and fellowship for your cancer training, as we call it, at Duke. And then after that, you headed to Wilmington, North Carolina. So what impressed me about sort of looking at your bio is you have won so many awards, and it's not necessarily all medical awards. A lot of that is recognition by people in the community about the contributions you've made and who you are as a physician. So if people want to go to Coastal Carolina Radiation Oncology and look up your bio, they can see all that.
Thank you.
And then you're also an author. The book is called When Cancer Hits Home. And so we'll talk about that a little later in the interview. And then you're also, so this is a book that's written for anyone, but then you've also authored a lot of professional publications because of clinical trials. Is that right?
That's right.
All right. Well, we got that down. So we have interviewed through Focusing on You a pathologist, Dr. McKinney, a surgeon, Dr. Bebb, Dr. Porchaska, a medical oncologist. And there may be some overlap in the interviews that we've had, but I figured reinforcement is always good for folks, and sometimes if things are explained in a little different way, they might understand it a little better. So what's your personal philosophy of care?
Well, I think my partners and I all agree that we want to provide excellent care in the community with a focus on technical expertise in radiation oncology specifically, and then also in the availability of clinical trials for common cancers.
Ah, very good. So we'll talk about that a little more. So what type of training do radiation oncologists go through, and what exactly is radiation?
Yeah, so radiation oncologists have a long way, like most doctors, as far as their education. So we do high school, undergrad, college 4 years, then 4 years of medical school, then a general internship, which is, it's usually a general one with medicine and surgery and a little bit of everything. Sometimes doctors will do just surgery or just medicine, but we get a good broad overview of medical care. Mm-hmm. And then we do 4 years of radiation oncology, one of which can be focused on research or subspecializing within radiation oncology.
Okay.
So
that's a lot of school.
It is, yeah.
So what exactly is a radiation oncologist? Like, what is radiation, I guess I would say?
So, as far as cancer treatment, there's several different ways to treat it. You know, surgery is pretty self-evident to most people. You see, something bad, you cut it out. Sometimes that's a major part of cancer treatment, and sometimes it's not, depending on the site and the type of cancer. But that's surgery, which is pretty easy to understand. Medical oncology, it used to be mostly chemotherapy, and so now it's not just chemotherapy, but immunotherapy and other systemic treatments that go all through the body.
Okay.
So one of the most common questions that patients ask, what's the difference between chemotherapy and radiation? Chemotherapy goes all through the body to kill small amounts of cancer throughout, whereas radiation is high-dose X-rays, usually, the way we deliver it, to a focused area or a region. So it can be a very small area, as small as a centimeter, something like the end of your finger, or it could be a mass as big as a softball. Generally, it's to treat the tumor that we see as well as microscopic cells in that region or area, but certainly not the whole body except in rare instances.
Okay, so what goes into treatment planning then for radiation? Like, who are the team members?
Yeah, so that's a great question. There's a whole entire team with each has their specific role. I think most patients feel like they know what the doctor does and the nurse, but in radiation oncology specifically, we have treatment planners who are dosimetrists, so they help us do the planning for the radiation. We have medical physicists that check to calculate that the radiation machines that are called linear accelerators, that they produce the right amount of energy and that we're treating patients as the doctor prescribes. And then we have radiation therapists who actually do the hands-on, putting patients on the machine, making sure everything is set up correctly the way that we have prescribed it. And so it is a whole team approach to treatment.
So that's the team at your office, and then you're also part of a broader team taking care of the patient. Is that correct? So
right. So we have a multidisciplinary team, including the surgeons and their team and the medical oncologists. We have a patient navigator that works with our patients as well as at the hospital. We have a dietitian that we work with that's specifically for patients who have cancer.
Awesome. So then how is a care plan developed for a patient that's maybe newly diagnosed with cancer? Can you describe how your radiation therapy might be recommended versus not recommended? How is that decided?
Yeah, quite often it can be the traditional route where the patient has either a bad symptom or a imaging test like a CAT scan or mammogram that shows something suspicious, and they get a biopsy, and then they're generally seen by, quite often, not just their primary physician, but a surgeon or a subspecialist that sends them to us. So generally, we're not seeing patients directly, quote, off the street. The patients aren't coming in to see us as a radiation oncologist because we're so subspecialized. Most patients already have a diagnosis. So then when they have their diagnosis, quite often the common cancers, prostate, breast cancer, lung, colorectal, head and neck, which is one of my specialties, patients will be referred to us from another subspecialist or a surgeon. And then when they come to see us, then we generate our radiation oncology plan of care, assuming that I, in my consultation, say yes, that we do feel like radiation is should be a part of your treatment to either cure you or help your symptoms.
Oh, okay. So it's not just part of the cure or getting rid of the cancer as far as we can tell. It could also be symptom management.
Yeah, absolutely. So about a third of the patients that we see are incurable when they first come to see us. So we know that their cancer has generally metastasized or spread to other sites to where we don't think we can cure the cancer. We can still treat it, and we can still help symptoms, and radiation is specifically very good at helping local symptoms, whether it be pain or bleeding or compression of nerves that are causing neurologic problems.
Okay. So I think I read, and you can probably address this better, of the number of cancer patients who get treatment. Is that 40 to 50% of them typically get radiation?
That's about right.
It was pretty high when I looked at that, because I think oftentimes people associate cancer with chemotherapy, but not necessarily cancer with radiation therapy. Is
Right.
that right?
No, that's right.
So then, why are there different types of plans for the same diagnosis of cancer?
That's a good question. So it really, most of the time it depends on stage, and certainly in a subset it depends on a specific scenario. But generally early cancers are treated a little bit different than more advanced cancers. Whether the cancer is curable or not can differ. In general, if we know that we have an advanced cancer we think we can cure, there's a lot of role for radiation plus chemotherapy concurrently at the same time. So
Like head and neck cancer,
exactly,
you mentioned?
Exactly.
Okay.
So if cancer is very early, it can be often surgery alone or sometimes radiation alone. We'll do something called stereotactic body radiation therapy, or SBRT, which is just focal high-dose radiation therapy. We can do that in the body. We can also do it for brain tumors, where we do radiosurgery, which is focal high dose, so that's radiation by itself. But if a cancer is more advanced, quite often it involves more than one. It might be all three: surgery, systemic therapy with chemo or immunotherapy, and radiation therapy.
Okay, great. So, kind of what you're telling me is we've come a long way. We're
Absolutely.
using radiation and chemotherapy at the same time. We're using as a directed therapy for if a patient's undergoing surgery, you might give radiation then, or like prostate seeds, or
Right.
there's some other things. So sort of the history of radiation has really probably had some growing pains, because if you're an older person, you may remember, radiation, people used to say, oh, that just
Yeah.
burns your skin. So I always try to educate people and say, radiation, we call it some skin maybe changes.
Right.
And then fatigue is one of the side effects. Could you sort of address where we've come from for the history
Sure.
of radiation, where we are now? And you talked about that a little bit.
Yeah, I think that's a great question. So, 30, 40, 50 years ago certainly is dramatically different than what we do now. I think in the old days, even really as late as the 80s and the early 90s, there were lots of cancers where we treated that might be deeper in the body, where the skin would get a reaction even though we didn't want it to, because we couldn't target things as well. Nowadays, really the main reasons we get skin reaction are when we need to have a skin reaction, when we need to be treating the skin. Patients after mastectomy for breast cancer, if they have a high risk of their cancer coming back on their chest wall, certainly they're going to get a skin reaction because we're treating that to full dose, because that's where the cancer cells could be residing, the microscopic cells. As opposed to, say, something deep in the body like the prostate or the lung or the skin reaction, we can target much better now so that the skin reaction is minimal. Same thing with fatigue to some degree. It really depends from a patient receiving radiation how large an area we need to treat. And so there are a lot of patients who have small tumors or deep-seated tumors in the body. Most men with prostate cancer, the fatigue from radiation itself is very minimal. If they're getting hormone treatments, that might be a little different, that going through the body making them tired. But the radiation itself, when it's targeted to a small area, rarely causes fatigue. As opposed to, say, if we had to treat someone for an advanced rectal cancer or something like that, where we're having to treat a big area in the pelvis, we're having to treat their lymph nodes, absolutely we can cause some fatigue then.
So the more targeted it is, probably the less symptoms of fatigue.
In general,
right,
yes.
in general.
Yep.
So, and I brought up prostate seeds, but that may be something that I know about, and you're very familiar with it. Could you explain? Because sometimes when I would explain radiation treatment to folks, it was easy to sort of talk about laser beams and
Right.
how it's really a targeted laser beam, but it's not just targeted laser beams that you treat. I mean, that there's different ways of radiation. So prostate seeds being one example. So could you describe sort of the different types of radiation that might be given for different types of cancer?
Yeah, I think most of what we treat is somewhat that analogy of laser beams. It works pretty well because it's a high energy. You don't see light, but it's a high energy X-ray. You don't see it, but it is focused and it's a beam. The other types of treatment that we do as far as internal radiation that aren't beams are prostate seeds, which are little pellets of radioactive seeds. They're impregnated on what look like little metal grains of rice. They're very small, and they're most commonly, the way we use them is for prostate cancer treatment that's localized. So men that are a good candidate for having their prostate removed, if they have early cancer, they can also, one of the other options is radiation seeds, where we put them to sleep and we put these little pellets into the prostate, and it has a very high, same chance as surgery, of curing men. Over 10 or 20 year, their cure rates 90+% for men with low risk prostate cancer. So that's another type. And then the other one that's been around for a long time is for certain female cancers like cervix cancer. Fortunately, it's much less common nowadays because of HPV testing and pap smears. But we do still see some patients with advanced cervix cancer. If the cancer is a little bit beyond the cervix, and can't have a hysterectomy or radical hysterectomy, they can be treated with internal radiation, which is similar to the seeds, a little bit different source, but internal radiation that goes through the cervix into the uterus and into the top of the vagina, and we cure a lot of patients that way.
Wow.
With that as a part of their treatment.
Wow. Okay, and then if a patient were to show up and have radiation, how does that process go? First, what happens first? They come to see a physician? Is that right?
Yeah, normally they would get referred, as I said earlier, from one of their other physicians. They come to see me or one of my partners, and we do a consultation, just a normal visit. Hey, what's been happening? And then we talk about their diagnosis, their stage of diagnosis of their cancer, and we review all their imaging and their pathology. We talk about the whole situation and say, here are your treatment options, and here's what the situation is. And then we say if radiation we think that has a role in their treatment, then we'll go into what are the potential side effects, the pros and cons, cure rates, etc.
Okay. And then do you also talk about risk versus benefit?
Yeah, absolutely.
And what does that mean when you're talking about radiation?
Yeah, I think that's one of the main pieces of information that patients should try to go into their oncology visits with, and that's partly why I wrote the book in that regard a few years back, is that you should try to have some of these questions in your mind. And so pros and cons, risks and benefits, for the most part, the benefit is going to be either increasing your cure rates or a palliation of helping a symptom. And then the risks really depend on what we're treating, where in the body, etc. Most patients, or a lot of patients, have thoughts of what radiation was like. Maybe they've heard of, hey, 34 years ago, like you said, and this skin reaction could be really horrible or what have you. And we have to tell them, hey, here's what it is now in the modern era with lots of the advances that we've had.
Right. And oftentimes patients may be uncomfortable asking about this topic, but I always encourage people to talk to their physicians about it. It's a different world than maybe it used to be. How do you feel about second opinions?
I never hesitate to send patients for second opinions if they want it. Most of the patients who I recommend it for, even when they haven't asked, are either unusual cancers that I don't see very frequently. So during my training at Duke as a major referral center, the docs at Duke, and when I was there, same thing, would see rare cancers. And so even though we're a fairly big community here in Wilmington and we serve pretty much the whole southeastern part of the state, there are certain rare cancers that we just don't see often enough to either to be good at. So there are certain things that you should be doing frequently If we're going to see something once a year, I'm going to send that patient up for at least their opinion at Duke. I may know in general what should be done, but even if I do, I want that confirmed at a big place, whether it's Duke or UNC,
Right.
which are obviously great world-class medical centers in our state. And so I never have a problem with that. And fortunately, the docs at UNC and Duke know me and know our practice well enough to say, quite often if I send them up there, oh yeah, well, Dr. Maguire said exactly the right thing, and you should go back to Wilmington and have your treatment. But occasionally they'll have something where I'm not comfortable treating or what have you, and patients should, I tell them, go up and have your opinion, and if they recommend that you have treatment there, you absolutely should have it there, even though it's inconvenient because
Right.
radiation is often several weeks or more
Right.
of treatment. Sometimes they really need that treatment there.
Right, and that's something I probably didn't follow up and ask you. So, patient gets a referral to see you. You look at everything,
Right.
and then where does the patient? What happens then in the treatment process?
Yeah, so normally if we decide together, yes, radiation is a part of the plan and should happen, then the next part is planning, radiation therapy planning, or what's called simulation, which is basically a dry run. The patient gets scanned. They may need imaging in a treatment position. Sometimes if it's, for instance, say a head and neck cancer, we'll make a mask that holds their head still so that we don't have to hit a moving target. And they get scanned. Quite often they may have other imaging like a PET scan or MRI, and we fuse those images together on the computer so that we can see their anatomy very well and tailor the radiation treatments to hit the tumor with a margin around it, maybe hit the lymph nodes nearby if we think that they're at risk for microscopic disease, and then minimize the dose to all the other critical parts, their spinal cord, their saliva glands, etc.
So I'm just going to ask you, microscopic disease, what does that mean?
So that means cancer that we can't see. So quite often, again, using the example of head and neck cancer, a patient may come in with a cancer in their tonsil with a lymph node, a big enlarged lymph node in their neck. And it's not unusual for patients to say, I noticed this big lump come up. I got some antibiotics from my doctor. It didn't go down. They sent me to the ENT doctor. They biopsied and it showed cancer. And then they get sent to me or one of my partners. So you can see that cancer, and then we might do other scans like a PET scan or something else.
Which looks for cancer elsewhere in the body, right?
But you need about 1 million cells in an area to see it, even on a scan like a PET or a CAT scan. So if you have 10,000 cells or 100,000, you're not going to see it on that scan.
Okay.
But we know that there's a risk, for instance, not just the lump here, but there might be cancer cells and lymph nodes right next to it that are not enlarged. And so that is where the microscopic part comes in. We can't see it, but we know that there's a higher chance for that. So that area might get a lower radiation dose, but we need to give it something so that we can decrease the chance of it coming back.
That's a great explanation of microscopic
Well, thanks.
disease. So, yeah, because it's hard to describe to people, and I like the way you talked about it. Sort of has to be a mass of cancer cells before we can detect it, and
Right.
that's sort of where we're still working on those issues to figure out how we can figure out
Exactly.
it's cancer earlier. I mean,
Yes.
one of the theories, I think, is that we have cancer in our bodies all the time, but our immune system detects it and gets rid of it. So
That's
why
right.
does some sort of escape that
Right,
whole, yeah.
right. And there are some tests that are being used now, just really starting to be used, like circulating tumor cells, the CTC it's called, where you will see, do a blood test and you can see these tests will show individual cells. And you would never have known that 5 or 10 years ago. And how
Right.
is that going to inform how treatments change? And that kind of leads to the clinical trials question and how we can
Yeah.
advance cancer care.
Yeah. So you mentioned a couple of things I wanted to circle back to. You talked about positioning and some aids like masks. And why do you do that for folks that are getting radiation treatment? Why is that so important?
The simple answer is so we can hit what we need to hit and miss what we need to miss. So, for instance, in addition to head and neck, another example would be prostate cancer in men. We know that the prostate, men who have a prostate still there and haven't had surgery, the prostate sits between the bladder and the rectum, and we know we want to hit the prostate with a minimal margin. We know there's some motion, and so we want to hit the prostate, allow for a little bit of motion, but not hit most of the rectum and the bladder, because that's where
Right.
the symptoms come from, and that's where we can hurt patients. And so that's really over the past 10, 20 years where the major advances have come for us to allow higher targeting, focal, what I mentioned, stereotactic body radiation therapy, or this SBRT, which is focal high-dose radiation. We can do that for men with prostate cancer. It's 5 total treatments. And they're same high cure rate, 90+% chance of being cured for men with early prostate, just like seeds or
That's
surgery.
excellent.
Yeah, so it's really a great
That's
treatment.
much different than surgery.
Exactly. And then the other instance would be lung. So there are a lot of patients who have a lung cancer that we see that's small. Then they're too medically inoperable is the term, meaning they can't have surgery because they have so many other medical problems that surgery would be too risky. Or they just don't want to have a big lung surgery. And we can do focal high-dose radiation in those cases. So
Cut down
that's
on the
that's
tumor
why the
burden.
motion really makes a difference. And so for a lung cancer, when we scan patients or do their planning, we watch them breathe and do what's called a 4D or 4-dimensional CAT scan, meaning 4D over time. So they're being scanned and we're watching the tumor move over time so that we can see how much area do we need to put around it so we can hit the tumor while it's moving and avoid the rest of the lung or the normal tissue nearby.
Right. And yet maybe have a small margin around the tumor that you're also radiating. Is that right?
For any, again, microscopic cells right next to it.
Yeah. And then you mentioned that like a prostate cancer patient might only have 5 days of radiation,
Right.
but then other people might have to go for 5 weeks.
Right.
What's the difference?
Yeah, that's a great question. Even men with the same disease. So prostate cancer, some guys will say, well, why can he only get 5 and I'm coming here for 9 weeks or 5 weeks? So that's a great question. And it really is, again, depending on their disease stage. If men with, again, using prostate cancer as an example, men with low Gleason score, or how aggressive the cells look under the microscope, if it's a 6 or maybe even a 7, and their prostate-specific antigen, the PSA blood test, if that's low and the Gleason score is low, their risk of having cancer cells outside the prostate is very low. So they can have a short treatment and have a very high chance of cure. Men, on the other hand, with a high Gleason score, really aggressive cells, when the pathologists like Dr. McKinney look at the cancer under the microscope, if it's very aggressive or their PSA blood test shows their PSA is way up over 20 or 30, those men need a longer course of radiation at a low dose. They need to have areas treated outside the prostate, again, to kill any microscopic cells in the glands near the prostate. And sometimes they even get systemic therapy like hormone therapy to kill the cancers that are relying on testosterone, for instance.
So it sounds like as we advance in medical treatment, it's not just one area of oncology. It's the cell biology, it's pathology, it's medical oncology, it's radiation oncology, and we end up moving forward because it's not one size fits all for treatment plans, even if you're talking about prostate cancer or breast cancer or head and neck cancer. Is that?
Right, and I think that's where some of the danger is for patients saying, hey, my neighbor got this or had this happen, and that may be available to you, or it might be that you, because you have a different stage of diagnosis or a different diagnosis altogether, that's probably not the best treatment for you. But absolutely, the advances in medical oncology, systemic therapy, and personalized medicine, personalized cancer care, we're becoming much more targeted. Like, this might be the general plan for someone who is like you, but here's the genetic changes in your cancer that are saying you need this medicine or this medicine that's going to help your cure rate be 10 or 20% higher than it would have been even 5 years ago.
And there's national guidelines, right? The NCCN guidelines.
Right.
But even that is not a cookie cutter decision because it may depend on other factors with the patient. Is that correct?
Right. I think NCCN is a great general guideline for doctors in the community and for patients to say, here's probably the general way things should go based on your stage and diagnosis, but absolutely, there are individual avenues that can be gone down that make each case different.
Right, right. So could you talk about the role of radiation in clinical trials? I know you've been involved in some clinical trials in this area as an investigator. So could you address that for us?
Yeah, my partners and I are very big proponents of clinical trials. So we feel like we want to not just treat the patient who's in front of us the best way we can, but also try and advance cancer care so that 5 and 10 years from now, we are not in the same place. We're always advancing. We're always learning something. So that's a big issue for us and something we really try to strive for is to improve cancer care in general. So, in fact, my partners and I have received the ASCO Clinical Trials Award a few years back, which was we were the first radiation oncology group in the country to get that.
That's incredible.
Yeah,
Awesome.
so we're very big proponents of that. And so for instance, when you're talking about second opinions, I'll see someone and I'll say, if you were to go to UNC or Duke to hear about this, this is the clinical trial that they would offer you. And we have this trial available here. So you don't have to, if you have a common cancer and we're very comfortable with treating you, you can have this treatment here locally and have really the cutting edge. Most of the clinical trials that we participate in are either phase 2 or phase 3, meaning phase 3 randomized trials are usually, here's the current standard of care for what you have now, and here is treatment, so that's treatment A, and treatment B is what we think could be the new standard of care. It could be better. And normally the computer picks, so the doctors who have designed the trials, whether it's me and my partners or someone nationally, say, we would be comfortable with you getting A or B. We're not sure which is better, and that's why we're doing this trial. So patients have to be comfortable saying, I could get this or this,
right,
because I couldn't tell. If it were a family member, I would say, yes, I'd be comfortable with you getting either. And so we've been fortunate to have a lot of patients who say, yes, we want the cutting edge treatment here in the community, and we're glad that you're offering this. And so we've really advanced cancer. We participate in that, and makes us all feel good, obviously.
So the good news is research does give us answers. But when you're talking about clinical trials, it does take a while, right?
Yeah.
Because you have to accrue or gather so many patients in order to make the data worthwhile. Then you have to come up with the results, and sometimes that has to be repeated a few times. Is that correct?
Absolutely. That's a great point. Yeah. So specifically our trial, my trial for head and neck patients with head and neck cancer locally, we started in 2011. I think we finished the patients. I think ultimately had like 50-some patients who went on the trial, and it stopped in 2015, but we had to watch them to make sure if their cancer was going to come back. And in the specific trial, we reduced the radiation dose to their neck in areas that we talked about earlier, microscopic risk. And as it turns out, patients did great. Nobody had the cancer come back despite us cutting the dose in half, which was great. But again, it took until this year for us to follow enough patients and then publish the study to now where we can say safely to other patients, hey, we can treat you like this safely. And so that, again, national trials, we wait on that as well.
Right. And then when those studies are published, you're sharing that with your colleagues all over the U.S. so that they're looking at that as a different standard of care, which ultimately would benefit the patient. Is that
exactly
right?
Yep.
So it's not like we just keep the secret here in Wilmington.
No, we try to spread the word. And rightly so. You should, doctors who are doing clinical research, obviously a lot of them are in academics, so their careers are dependent on publishing things. But for us, that's not the case here in the
Right.
community. But we care enough about it and say, hey, here's a side effect that we saw that we weren't expecting. Luckily, that didn't happen for us, but sometimes it does. So you really need to share so other doctors don't make
Right.
the same mistakes. And we can learn and say, okay, we learned this, now we can build on it, not reinvent the wheel.
Right, right. And I like the way you worded it, and you talked about targeted therapy, because radiation tends to be very specific, and it gets more specific and more finite the more we know about it. Like you said, cutting the dose in half probably, I'm assuming, significantly decrease the side effects that somebody went through, short and long term. Is that right?
Yeah, we did quality of life surveys, so patients really did well. We didn't compare it head to head to the old treatment,
Right.
But historically, comparing to what we used to do, yeah, there was a big difference.
Right. Because I know that's sort of tough treatment to go through.
Absolutely.
Yeah. Yeah. So, switching gears a little bit, and previously focusing on you episodes, I've asked the physicians about tumor boards,
Okay.
which tumor boards sounds sort of like an odd name for what it actually is.
Yeah.
So can you explain your role in a tumor board? Like, what is a tumor board? Why is that in existence, and do all patients get presented, or just some of them? What go over the tumor boards?
That's a
for
good
us?
question. So, yeah, tumor board is a kind of a funny name. It's generally a time where all the cancer specialists can get together, and usually one of the doctors who has seen the patient will present the case and the patient's symptoms and what happened, and we'll look at the imaging and the pathology, and we all come together and say, hey, this is what we feel is the best treatment. Sometimes we'll do that before, ideally we'll do it before treatment has happened. So they've just had their diagnosis and the staging studies, maybe the imaging, and we'll say, here's what should happen next, A, B, and C. And so you have radiation oncologists like myself, a medical oncologist, surgeons, the pathologist, radiologist, everybody's in the room, the support staff quite often, the nurses, etc. And then we plan things out. Not everyone has their case prospectively presented. We have breast cancer tumor boards that are specific, and GYN cancer for female cancers. We have a lung cancer clinic that's a multidisciplinary clinic where patients come and are seen right then, and all of their doctors are seeing, multiple doctors are seeing them at the same time. So we will be probably at the hospital rolling out more of that, just like the lung cancer clinic, starting a head and neck cancer clinic for patients who, it's a tumor board where the actual patient comes and is seen by multiple doctors on the same day. And so that's done a lot at big university centers, and we're kind of trying to offer that more often here for patients with different types of cancer.
Yeah, it's interesting from a patient perspective, because I went through one of those multidisciplinary clinics for breast, and here I am, an oncology nurse, right? I took another oncology nurse with me and my husband, because it's so overwhelming emotionally, and it's a long day. So the advantage is you're seeing everyone in one day, and you're getting some answers, and it really works as far as that aspect. But I can tell you to always take someone with you, even if you're a doctor or an oncology nurse or a pharmacist, or you're, as I call it, in the profession, because it's just a lot of information.
Yeah,
so,
that's great advice.
yeah,
Absolutely.
Yeah. So what about if your patients come in to see you, and then they go home and they want to do a little more research on radiation oncology, or what's going to happen to them, or do you have websites or any sort of, I don't know, YouTube videos that you would refer people to so that they can sort of review what you've talked about?
Yeah, I do. I mean, that's part of the reason why I wrote the When Cancer Hits Home, because of my experience in my family and what you had said. Gosh, if you're not in the medical field, you can really feel like out of sorts and like a maelstrom is what's hit me,
Right.
which is certainly understandable. So I try to give all my patients a copy of the book, even though it's a few years old now. I think I wrote it in 2010, so some of the information is a little bit dated, but the basics of it are there.
And what are the basics? Tell everybody what the basics are.
Yeah, so the first part of the book is about things you can do lifestyle-wise for prevention, which is patients who aren't diagnosed, maybe family members, like what can I do to minimize my risk of getting cancer. And the bulk of the book, though, is the top 20 cancers in the U.S. And so each chapter is a common cancer, whether it's breast or lymphoma or prostate cancer, et cetera. Talks a little, there's a case in there that's related. It's not patients' names, et cetera, are not in there, but related to some of the patients I've seen in the past. So there's a case for each type of cancer, and then there's a discussion of risk factors, staging, diagnoses. Most of that stuff has stayed the same. The treatments, particularly from a medical oncology standpoint, have changed quite a bit in the past, even 6 or 8 years since the book
They keep changing.
Yeah, it's so dramatic. So some of that's not up to date, but a lot of the basics otherwise are in there.
So explain to me where that title came from, When Cancer Hits Home.
Yeah, so both of my wife's parents were diagnosed over a period of a couple years when we were in our 30s, and they were, I guess, her mother was 60 and her father was in his early 70s. So with lung cancer and prostate cancer, her mother was down here staying with us when our daughter was born. This is a long time ago now, and had some back pain, and it just didn't go away. And we got her seen, and ultimately she had a scan, an MRI of her back, and I remember going in with one of the radiologists and saying, "This is cancer," until proven otherwise, which was terrible. She had been a smoker but had quit. My wife said, "Mom, you're not going to have my wedding dress in your house until you quit smoking," which she did, but not soon enough. You know, she had smoked for decades, so that was rough. But that was her mother, and then her father had prostate cancer that had metastasized. He was a kind of a tough guy. A roofer, owned his own roofing company in Philly. Great guy, but very tough. Never went to the doctor. And so when he was diagnosed, his PSA, the blood test, was in the hundreds, which meant that the cancer had spread elsewhere. And so we went through that with him. And then we went through it with my dad with stomach cancer. So we had a lot of cancer in our family over a period of really just a few years. And they have all since passed away. And my mom as well, not the only one not from cancer. So that was really the impetus for it, and knowing that a lot of my patients, when they come in, are, like I said, they're frightened. They don't have the medical background that I have when I was with her, my in-laws or my father, and so I know how much harder that was for those type folks. So that's why I wrote it.
Well, that tells me you're passionate about what you do and who you are and why you care for your patients. So that's wonderful. So I appreciate you sharing your story, because sometimes that's very difficult too, when you lose someone to cancer and you're frustrated because you feel like, well, maybe something could have been done. I mean, with your mother-in-law especially, there are lung cancer diagnoses not associated with cigarette smoking, and everybody sort of equates those two together, and sometimes that's not even the case. I mean, we want to do everything we can to be healthy. I always use the example of, why did that 102-year-old French woman smoke and drink red wine every day of her life, but yet there's a 36-year-old who smoked and then she got cancer and died. So we don't have all the answers yet. So
No, I know. I think that's next on the horizon. Maybe not next year, but hopefully in our lifetime we can kind of predict that people's genetic predispositions, but right now it's
We don't know. So we talked a little bit about this, but what changes do you see on the horizon for radiation therapy specifically?
I think a lot of it will be more focal therapy. There are patients, men, for instance, who come in with prostate cancer who talk about proton therapy, which is a different type of focused radiation therapy that's in several centers across the country, but hasn't been proven to be better than photon radiation, which is what we deliver with all the fancy computer planning. I think proton treatment is one method of advancement, but it needs to come down in price. A lot of these centers are literally $150 million to build, so centers are feeling like they can't just treat focused cancers. They need to use it on men with prostate cancer so they can pay for the facility. So I think when that comes down in price, that would be nice. I think in general for radiation therapy, it's more and more focused, more and more computer planning that allows us to do things potentially remotely. A lot of, like everything else, a lot of technological advancements that will allow us to cure more people and or reduce side effects from treatment.
So a lot of radiation therapy has to do with technical things.
Right.
So I want to ask you if you have any parting words of hope for our audience that's watching, if they either have a cancer diagnosis or know someone in their family with a cancer diagnosis.
Yeah, absolutely. I think obviously hope abounds. That's what this is all about, and that's why I've been, it's been a pleasure to be part of this with Kenny and Elizabeth for so long and what they do in the community. Most people, when they get the cancer diagnosis, their heads start spinning and they start to lose hope. And I will say the majority of folks often have a curable cancer, and so it might not feel like that when they're first to get a cancer diagnosis, but the folks who have a curable cancer, we will bring you there. We'll get you there. The folks in our community together, I think we work very well with the surgeons and medical oncologists. And once people are, for instance, in our office and they meet our staff, they're just much more calm and they feel more hope because they know that, hey, we can do something for you. Even for patients who have incurable cancers, is there a hope that they're going to live forever? No, but none of us are. And so then it's really a hope for a better quality of life. And quite often, more often than not, we can do that. We can help provide that, a better quality of life, even when they can't. So there's always hope, even if there isn't a cure for everyone.
Well, that was beautifully said, and we really appreciate you coming in tonight and explaining to everyone what you do in your office along with your whole team, and really appreciate all of your help for this.
Well, it's my pleasure. Thanks for having me.
All right. Thank you so much. And that's it for this evening. I would encourage everyone to go back and watch some of the other Focusing on You episodes. I think it'll help you understand sort of the puzzle pieces that go into cancer diagnosis and treatment. And hope to see you again soon.